Good morning and welcome to the January board meeting being held on Burns Day. So happy Burns Day as well to everyone. Are there any apologies, Ruth? We know we have an apology from Jean Boardman. Any other apologies?
I don't have any other apologies received, thank you, Chairman. No.
Any declarations of conflicts of interest? Alistair.
Yes, thank you, Boyd, and good morning. I had considered making a declaration of interest in my capacity as a Highland councillor, but having applied the objective test and looking at the items on the agenda today, I feel I don't need to do so. Boyd, I will need to leave at 13:45 for a personal appointment, so apologies for that.
Yeah, thanks, Alistair, understood. Heidi.
Thank you. Just to let you know, I no longer have a potential conflict of interest. Okay, thanks.
Okay, thanks. And we move now to staff recognition item. And today we have allied health professionals with us from the physiotherapy teams. And I'm really delighted to welcome these three colleagues who are going to tell us something of their experience throughout the pandemic. Today we have with us Karen Brandy, who's the lead team physiotherapist, Kieran McManus, First Contact Physiotherapy Service, and Jude Arno, I hope I have pronounced that correctly, Jude, clinical lead MSK primary care physiotherapist. And you're all very welcome, and I'm going to ask Karen to lead off with the presentation.
Many thanks and good morning to you all. I think that Ruth will hopefully share one or two slides and then I'll make a start.
Just 1 second, Karen. I'll just get that up just now.
I'll maybe just make an introduction if that's okay while that's happening. So I've been the acute physiotherapy lead since December 2019, but I have myself worked for NHS Highland since 1994. So I've got a sort of range of physiotherapy experience within NHS Highland. Great.
I think we're good to go now.
Yeah. So we all know what the hospital looks like. So I'll maybe just take the first slide when you're ready. That would be great. Perfect. Okay, so just thought I would just give a brief summary of what the team's all about, really. So the team are based in Regmore Hospital. We're organised into 5 units covering all clinical specialties. And our focus is mainly on supporting discharge and preventing admission, and we do that through the work within the hospital and both also managing complex respiratory, both adult and paediatrics in the community. We also have a 24/7 respiratory system service rather as on call, and we have sorry, next slide please. We have a 50 head count of staff with a variety of grades, and sorry for the complex diagram there, that's not for you to read, but it's really just to show that we've got quite a big mix of staff. We've got a mix of specialties and organised into individual teams, as you can see, some of which are specialists, some are rotational, and this provides a well-trained, flexible workforce. The staff group themselves will also present with a wide variety of experiences, emotions, perceptions, and also coping strategies. So the leadership of the team is quite challenging at times, but also quite interesting. So the next slide, please. So when the first wave hit, weirdly, most staff were actually quite excited, and physios as a profession will consider that we have excellent problem-solving skills, and we knew the potential of COVID was certainly a big problem. Staff were maybe somewhere a little fearful at the beginning, and at the time they dreaded getting COVID and not knowing what it would mean, similar to the general public. General population, but these fears didn't stop us from delivering services. And we made an early decision that because COVID's a respiratory illness, we really wanted to understand how how our respiratory skills could be best used. And we were almost very much aware of the patients that were indirectly affected by COVID. So we split our 5 teams into 2, a respiratory team and a rehab team. And this allowed the expertise within the teams to provide teaching, training and support to less experienced staff, both within NHS Highland Physio team and also other professions. And it really allowed us to minimise the staff contact with or exposure to COVID. So the respiratory team got their head around the sort of AGPs, the PPEs and the treatment techniques, whilst the rehab team focused on intensive rehab for the patients that were unaffected physically by the virus but indirectly affected by COVID. So there was a lot of focus on facilitating discharge from the hospital at that time. I was part of the bronze group, which allowed first-hand sort of two-way communication, and this was, for me, was essential in managing the impact of COVID on the delivery of our services, and it supported my ability to lead the staff through the changes that they were facing on a daily basis. Sorry, next slide. So this just represents a few of the challenges that we had to deal with. So the puzzles and problems to solve, you know, in the beginning, we were all in this together, and the pace and enthusiasm for learning was really high. At that time, we were really keen to share our learning with community teams because we knew there was potential for patients needing ventilation in remote areas, such as Caithness and Skye, but we found this quite challenging at the time, as these teams are not familiar with this type of work. Over time, I would say that staff resilience has waned, and many staff groups, like many staff groups, because of the prolonged nature of the pandemic, and it's been difficult because of the social distancing and working from home and the sort of virtual meetings, but we've really tried to do our best with that, and that's not unique to physio. The acute physio team's not been badly affected by COVID absence. However, recruitment's been really challenging, and we have found that, for instance, students that are graduating are less inclined to travel. And we've also had staff members that have moved closer to their families. So a couple of staff members who have been, who have families abroad, found the travel restrictions really meant that they wanted to be with their families at that time. So we lost those members of staff. We also found patients were very deconditioned, and they still are because of the effects of COVID and isolation, taking more time to rehabilitate and often quite affected in terms of mood, which is quite challenging for staff to deal with on a daily basis. In terms of progress, we found through our meetings with colleagues across Scotland that Regmore was one of the few hospitals in Scotland that maintained physio services within stroke rehab. And that was a conscious effort on our part. And what we found is that actually COVID affects more than the respiratory system. So we're seeing a lot more strokes, a lot more vascular problems. So we found that it's been really positive to invest staff in this area. And in terms of respiratory, we've really embedded ourselves within critical care. We understand the roles of the nursing staff a lot more. They understand our roles, and really between physio and nursing, we have developed much more of a mutual respect, which providing overlaps and continuity and efficiency for patients. So that has been a real plus for us. And finally, we are really managing to keep face-to-face student placements going, because we know there's a strong link between successful student placements and recruitment. And we've had really very positive feedback from students and universities. And the final picture there is just a nod to the sort of IT solutions that we've had, and even meetings like this. You know, it's great to get people together virtually. We've done a lot of virtual work with patients, virtual classes. But one thing in particular is a service called vCreate, which is part of our paediatric service, and this allows a virtual follow-up of children who are discharged from SCBU. So the parents will make videos of their children doing, you know, their movements and whatnot in their own environment, where they're much more relaxed than a clinic setting. They can upload and send these, and they're able to be virtually assessed by a specialist physio. So that means that patients don't have to travel, and parents have really welcomed this. So this was pioneered in the Highlands, and it's now been rolled out nationally. And it was presented at the NHS Scotland event in 2021. So we're really proud of that in particular. So the last slide for me is just any questions slide, but I'll maybe hand over to Kieran or Jude for their bit. Thank you.
Thank you, Karen. Your colleagues want to come in now.
Hi there. Thanks very much for the invitation to speak today. Ruth has also got our presentation, and just while she's setting that up, I'll introduce myself. My name is Kieran McManus. I'm one of the clinical leads for the First Contact Physiotherapy Service for North Highland, and this is Jude.
Hi, I'm Jude Arno, and yes, thanks Boyd, perfect pronunciation on the Arno there, so thanks very much for having us along today. Really looking forward to telling you a little bit about our service and how things have been for us.
So, as we described, our service is called the First Contact Physiotherapy Service in General Practice, and between Jude and I, we cover the whole of North Highland, all 65 practices. Ruth, you can move on to the next slide. I'm just going to ask Jude to basically describe what the FCP service is and what it aims to do.
Yeah, thank you. So the FCP service is in response to the 2018 GP contract, and our implementation started in April 2019. Over the past 3 years coming up, we have recruited 30 clinicians who are based in the general practice surgeries across the 65 different practices. It's been a very rapid implementation of this new service. Our aim of the service is to reduce GP workload. And I'm going to pass on to Kieran now. Next slide, please, Ruth. And so Kieran, what is an FCP?
Essentially, an FCP is an advanced physiotherapy practitioner. So at the top of their game, they are an independent prescriber, they're an injecting therapist, and their remit is to provide fast access to a musculoskeletal opinion, diagnosis, assessment, and guidance of management of musculoskeletal conditions. We can also arrange onward referral and facilitate any further management that the patient might need. Now, in terms of a typical example of a patient, essentially you might have an osteoarthritic knee that during the pandemic we were delivering these consultations remotely. So we were either based in the practice using remote consulting, or we were based in a hospital setting, being able to connect to the practice systems, because all our record keeping is on GP practice systems. And that's an important point about shared clinical records with the GPs, because that facilitates the service and how it's based in general practice. Now, so the next slide, Ruth, I'm going to get you to describe what do the patients in practice think of our service thus far.
So we were really keen to get some feedback and some evaluation of the service from our users. So we did an 8-week cycle where we had 475 surveys, and this slide just shows some of the feedback that we got from the patients. And we asked patients across the service what they thought of First Contact Physiotherapy. As you can see, there was some very positive physiotherapy experience quotations there from the patients. The main themes really that came out was a high degree of satisfaction, the reassuring nature, the professional nature, the very positive nature, and the helpful nature. The other main themes that came out were around access to our service. And what we found was that patients really appreciated the ease and the directness of being able to book directly for a first contact physiotherapy appointment. It was very quick to see the physiotherapist. And also, probably the biggest thing was that it was locally based in the general practice. That theme came out again and again. Next slide, please. We also asked the practice teams, what is the service doing well and what could the service do better? This has been a round of another 8-week cycle of service improvement. And the practice teams, interestingly, the non-clinical staff were the ones we surveyed, and they interestingly came up with very similar themes to the patient's feedback. So the access, it was high level of satisfaction and value of the service from both the practice staff and the patients. The fast, easy and direct access, and that we were based in the practice. The other thing that the practice staff highlighted was that the FCP can give a complete package of care so that they can manage the whole patient's MSK journey. And that really lends into us being, in the right place, delivering the right care to the right person. The challenges for them were more appointments, please. We just want more of you, and we would like some cover. And they also highlighted it might be a value for us to look at raising public awareness of the service. And that's something we're taking forward as a patient experience group within the service itself. Next slide, please, Ruth. So I guess it's been a very quick 3 years. It feels like that. And this is a slide just to really kind of try and capture some of our main learning from introducing this new service. So Kieran, what's your thoughts?
I think the first point there about the support from GPs. Essentially, our job really is to try and reduce the pressure on general practice and general practitioners. But also that requires some collaborative working with them and a shared vision. And so it's been highly rewarding to work with that GP group because they've been very supportive, they've been welcoming into their practice, they've been providing rooms, they've been able to share patient discussions. And so that openness has really been the top learning point for me. The other element that we've had to be able to learn from is the flexible nature. So during the pandemic, we've been able to consult remotely, but also deliver face-to-face appointments where possible. So alongside general practice, they've been delivering face-to-face appointments right through the pandemic, and we've tried to match that and to be able to try and deliver that face-to-face clinical appointment as it's needed. And around that basic local population is pretty important. The other support that I would say we've really benefited from, like Karen was saying, was e-health. They've been essentially in trying to help us to be able to deliver this service. And I suppose the other learning point really is that realistically we've been able to show that we've once we're given the opportunity to interact with the patient at the most appropriate point, that's when as clinicians we've been able to try and make them the biggest bang for our buck, really. And the clinicians themselves have really felt that rewarding nature of being able to consult with patients at the very early most point, rather than the patient having to go through several steps before we get to us. And again, the next slide, Ruth, our last point is also to welcome questions. I'm sure there might be some. Thank you very much.
Thank you.
Thank you, Karen, Jude and Kieran. And can I now invite colleagues to make contributions, ask questions? First up is Deirdre.
Thank you, Chair, and thank you very much for your presentation. But most of all, a very big thank you for your service, which I have been very lucky to benefit from over the past while. I was unaware that this service was available, and my GP suggested it to me, and I was delighted. I got a very speedy appointment. It was within days, and you referred to the benefits of getting specialist treatment, specialist attention at the right time, at the right place, and I can just fully endorse this. It's just a superb service. Talking to the physio, he said that he's very busy indeed, which doesn't surprise me. And one thing I did intend to go back and ask for follow-ups, just for questions. Would there be possibility of engaging with the physio simply by email instead of taking up a valuable appointment just for simple questions? So a big thank you and just a small question.
If Karen or one of the team wants to come back on that question from Deirdre.
Yes, I think, I suppose we're ultimately trying to be able to be as available as possible. And I guess from a connection point of view, we're trying to be able to align ourselves with the general practice teams. So I think, in terms of the communication back and forth between patients and the clinicians, I think we've been trying, that's probably a good conversation for us to have with practices to be able to try and improve that communication line. And so what we're being mindful of is trying to not set up something that's not aligned with the practice teams. And so, the practices have an admin account where they'll be able to get questions coming in. So that probably is the best route for that. And it's probably worthwhile us having that conversation with the practices, because that's who we're trying to align ourselves alongside.
Yeah, thank you.
Thanks for the feedback.
Yes, thank you.
You're mute, Lloyd.
Thanks, Alex. Alex, you're on.
I don't know if it me, that's why I asked the question. Thanks very much, folks. Yes, I'd like to echo what Deirdre said. It's obviously been a big challenging time, and you've risen to the challenges, as most of the NHS Highland staff have done. In terms of the impact of COVID, now thinking about the impact of the so-called long COVID, what's happening with that? Obviously, your teams are going to be involved in some way in dealing with that, I would imagine, at least to begin with, in quite a major way in dealing with that. How are you going to pull that forward? What's the sort of timescales you're looking at, or is it something that you're just going to have to deal with over time? Thanks.
So in terms of long COVID, we are seeing patients through our respiratory service. So we have a physio who manages the sort of outpatient, initially the sort of chronic respiratory, but we know that some of the long COVID effects relate to dysfunctional breathlessness. So she has picked up a number of these patients. I've been working with the AHP lead in Argyll and Bute, and she has a real passion for long COVID. So we have a post expressly looking at the respiratory element, but we are struggling to recruit that post. This is an advanced practice post, and we haven't recruited it. So we're now shifting our attention a little bit to the rehab element, which will encompass the breathing side of things. We're looking to hopefully move that into a more of a community setting. But we are working very closely with our colleagues, our respiratory colleagues, but also the COVID team, the COVID follow-up team. And we have those links developed, but this is where the sort of crossover between acute and community, we need to really kind of forge those links in relation to that. So I'd like to say it's in hand with recruitment challenges, and it's certainly very much on our radar with the numbers of people. The other thing I would say is that we do have an ITU, or we're working on an ITU follow-up, because we know that there have been a number of people affected by COVID, however, some of them in a very serious way, and they've spent a great deal of time in intensive care. And that goes to not just the COVID features, but they also just long-term ventilation, long-term paralysis. It really does take its toll physically and mentally. So there is some psychology input, and yes, that's certainly on our radar and in the planning with the critical care teams. Yeah.
Thank you, Karen. Graham.
Thank you for that. That's been a fascinating insight, and it's been great to see the way the service is continuing to adapt and change. On the question of on the new service linked to GPs, I'm assuming that's now a national rollout, and is there an evaluation taking place about the national service? It was really good to see that you had actually taken some initiative and started some self-evaluation. But I wondered, is that being rolled out nationally as well? Thank you.
Thank you, Graham, for your question. So yes, as you say, we've got the local evaluation in place, and that's going to come on to some quantitative data as well as the qualitative data. So we're looking at evaluating actually what's happening with the service locally and how it's meeting its aims. Nationally, we link into a national group of the services that are running across the country, and we are all at different stages. There are different stages of recruitment and different stages of delivery. I think I read a recent summary of that from the primary care modernisation group that said a lot of the boards are sitting at about 40% delivery of first contact physiotherapy services. In Highland, we're sitting at about 70% at the moment with our clinicians in, as I say, the majority of the practices. So we are all at different stages. There is a minimum data set as well that we will be looking to come together on nationally to look at that evaluation. Kieran, is there anything else?
Yeah, it's probably interesting that when we speak to the different leads and different FCP leads and different boards, everyone has got their different thoughts on what information we should be capturing. And I think going back to the previous point, what we're trying to do here in Highland is capture information that different parts of the stakeholders within the service are looking for. So obviously, GPs would be looking for information about the patients that are being seen, if they're coming directly from, say, reception, or if they're coming from still seeing GPs first. And I think that goes back to that communication about how we can get the population to be able to understand that the service is available and you can book directly from reception. So that, so the GPs are looking for that component, whereas as physiotherapists, we're probably focused on other different quantitative information, like the types of patients we're seeing, the amount of injections we're delivering, the amount of referrals that we triage on, how much we're managing ourselves. So I suppose there's an element where everyone has a certain thought about what information we should look at, and I guess the data we'll be collecting, we'll be trying to deliver that for each different stakeholders so that we can try and show everyone that we're trying to do what they're wanting us to do.
Thank you.
Thanks, team. Louise and then Anne. Louise.
Thank you very much, and thank you. I just wanted to thank you on behalf of myself and the teams for all of the hard work you're doing. I know it's been a long and challenging couple of years, and certainly from speaking to some of you, you've been doing some great things in that time. One of the things I also wanted to check out, which has slightly been answered already, it was about that national link up and how we're facilitating that, but also at a local level, how we're doing that with the wider integrated teams, the community, etc. And if there's more we can do in that direction to work out how we sort of almost enmesh what we're doing, but not lose the focus of the particular work.
So thank you for the question, and I alluded to that a little within our, my presentation. We did, when COVID started, and it was very much a respiratory illness, an acute respiratory illness, we did struggle to what would be the word, to engage the community teams that are maybe not familiar so much with, they're certainly not familiar with ventilators and whatnot, and there's, Rigmore is the only physio team that have an on-call service for respiratory within Highland. So, I'll be honest, it was, and I think it was probably a fear. It was reported to us that they were nervous of the situation. So we did our best to try and share our learning, because it was new to us, for sure. But I would say that we don't have an overarching physio lead, so this does make it challenging. I know this is something that that is being looked at within AHPs, but that for me would really provide some good you know, collaborative work and reduce some of the efficiencies. And for us, it was down to us on the ground, you know, the clinical specialists in ITU liaising with the physio lead in Caithness or in Skye or whatever. And you know, and it was difficult to engage. So I think, you know, in terms of taking learning from that, you know, having that good collaboration with certainly the acute learning, but also the longer term conditions and going forward would really help to bridge that gap between the work that we're doing here in acute and the work that's being done in the community. So some kind of oversight from a leadership level, but I believe that's in hand, and we're involved in those discussions, and certainly very, very happy with that. But that would be something to address going forward, I would say.
Super, thanks.
Just come in there and say, oh, sorry, Boyd. Just come in there and reinforce Karen's point, really, is that we've a credit to the staff and a credit to those of us in those positions of really kind of rolling our sleeves up and getting in and communicating with who we needed to communicate. And it was challenging while we were trying to, you know, get everybody sorted with kit to deliver, you know, remote consultations, as well as try to keep that service and the wider links going. So absolutely reinforce the point of some strategic oversight would be a real asset to our service.
Thank you. Anne, and then finally Pam.
So thanks again for that presentation. And just following on from that last point, hopefully you'll all be aware that we've started the process of pulling together our Together We Care strategy for the next 3 to 5 years. And I just wondered what your own ambitions would be for your service in terms of that strategy and where you would like to be in 5 years' time. Thanks.
Who wants to make the pitch?
Well, I suppose it's unusual for me talking about that because I'm moving on to a new post. But from the FCP service, I guess one of the key points of our service is where it sits, because in terms of even the implementation, we have felt that, not piggy in the middle, but we're certainly very well placed to be linking in with our hospital-based colleagues, our community colleagues, but also wider community services. Mm-hmm. So I think having that local placement in general practice has been able to help us to be able to link up that patient pathway. Mm-hmm. So one of the key things we talked to the staff was about in the very beginning was one of our roles is to try and make that as efficient as possible for the patient, so they're not having to go to lots of different people to try and get information. We're trying to link that all up so that they get as many answers as possible to their question, and also we're also trying to be able to facilitate the community support that's out there. So local service delivery, whether it's health service based or third party. We're trying to be able to make sure that connection is made between healthcare and community care. Mm-hmm. Not so community care almost means health related, but it's not necessarily. It's even third party delivered. So I think that the longer that the service is in place, the probably more those connections can be built up. There's lots of work out in the West, in Lochaber, to try and make those community connections. And so having those advanced practitioners in place probably just enhances that connection as much as possible. So I think over the next 3 or 4 years, I think that's the direction we'll be going, but while trying to be able to still meet that remit of offloading work on general practice.
From me, one of the real focuses needs to be recruitment, and I would like to see you know, we have a lot of people in schools that are interested in doing physiotherapy, but in order to become a physiotherapist, you have to move away from the Highlands. We try and grab them back and have them in for placements and so on, and we've been successful. We have quite a number of people that come back to the Highlands, but some of them, you know, they stay away. And But we've also got some really, really good homegrown talent in the healthcare support workers. So I would love to see things like modern apprenticeships coming through for these people that can, you know, they can work here, but they can also learn and become a professional. We've seen people going through from healthcare support workers into qualified staff, and investing in staff at that level is really important. But at the other end, we've also seen a lot of movement of sort of advanced practice in the MSK field. Sorry guys, but there's not a lot within the acute physio service, and we've got hugely skilled staff doing some very demanding work. For instance, you know, building a service for ventilated children in the Highlands, you know, and I'd really like to see some advanced practice roles within the acute service to really provide that high quality care for these patients, and again crossing over those community boundaries. So yeah, absolutely, that would be certainly vision from a staff perspective, and you know, continuing to support the patients as best we can with preventing admission and helping that flow through the hospital so that they're not spending too much time in hospital, and getting their assessments and rehab where they need it, you know, which is very often at home in their own environment. Yeah.
Just follow up on Anne's point, to encourage you to submit these views to Lorraine Cowie, who's heading up the development of the strategy. It'd be very welcome to get your insight into what your needs are. Finally, penultimately it is now, Pam.
Thank you, and again, like others, I'd like to thank you very much for everything that you do and for the presentations, which were hugely helpful. I'm probably on the same vein of the strategy and looking to the future. Then it's fantastic the way that you've kept things going and the way you've developed things in the wake of, during and in the wake of what we're experiencing. But looking to the future and that strategy development, there's probably a couple of things that come to mind for each party that's in. So I'll start off with yourself, Karen, in terms of that respiratory pathway, and you know, the knowledge we have of the prevention and self-management, self-care end of a respiratory pathway, pulmonary rehab, all these things that are evidence-based and effective, and just to get a better understanding of where we're at with that and how we can support that in our planning more effectively. And more recently, a stronger emphasis coming through again around remote monitoring and how do we remotely monitor patients so that they don't have to come in, and particularly with Omicron, where it's not so, people that don't get so unwell, there's a greater opportunity to treat them with their medication and with remote monitoring. So just something around that. And briefly, from a general practice perspective, I'm probably going to say something here a bit controversial, but you know, whilst the GP contract was absolutely about addressing the workload of GPs, it was more about the multidisciplinary team and the breadth of that MDT and what they could bring to the party to improve quality. And I think that, you know, that's what I'm hearing from you. This is about your expertise in that space and what you bring to that party and that early intervention, and what that prevents, you know, in terms of the rest of the system. And I think the early evaluation you've done sounds really good, but I'd be really interested actually on both accounts, Karen, from you and Kieran and Judith, to understand, so what does that do to our system if we do this well? How does that shift and change our system? And therefore, where do we need to invest or work more strongly with our third sector partners and indeed with communities? And people in place is where I like to start, and outcomes for people. So it's just some food for thought, and you may have something to come back on that, but I wouldn't sell yourselves short about describing it as taking workload off for the GPs, which is really important because GPs were not necessarily the right people for people to be seeing, but instead how you contribute to that quality, and Deirdre set that out very well.
Thank you, Pam. And just coming back on that briefly, one of the main comments we hear time and time again from our GP colleagues is it's so good to have the physio in the building with that MSK, particularly the MSK expertise and knowledge, because when a patient comes in with 3 or 4 different conditions and they then say, oh, and I've got a sore shoulder, they can ask them to come and book in with the physiotherapist for that expert opinion. So we very much benefited from that value that we've brought into general practice. It also gives a lot of satisfaction for the physios who have moved into these advanced practice roles to have that at that very point of care, which is really satisfying for us too.
Yeah, and I appreciate your comments as well. We've done a lot of work with the respiratory pathways, and we're working with the tech team right now in relation to remote monitoring as well. So it's on our radar, and we're hopefully part of that. But yes, I can really see the advantage going forward on that, and I really appreciate your thoughts on that as well. Yep.
And finally, Fiona.
Yeah, thanks, Boyd. And I just really wanted to pick up on the comments around the approach to our kind of staffing in the longer term. We're absolutely singing from the same hymn sheet here, and we've got, as well as the strategy, our workforce board is looking at this, and we're doing a piece of work around attraction, recruitment and retention. We've been, for far too long, we've been continuing to look to recruit the same people that don't exist where we need them, rather than looking to kind of grow our own. So that's definitely part of our plans, and I've captured all your names, and I'll be making sure that we link you in to the work, because I think, it's an opportunity for us, but actually it's an opportunity for our kind of our young people in our communities as well, to see realistic options, to kind of grow a career without having to leave Highland necessarily. So absolutely endorse what you're saying and look forward to working with you on it.
Yeah. So I appreciate that. I have my own vision of having a physio course at UHI, because we've done that with nursing and midwifery previously, and why can't we have AHP there? Because then we can have all the people that come over from other countries to train, and they can come and spend some time with us here, and yeah. People would love to come to the Highlands, I think, and study. So yeah, that's maybe a longer vision. I don't know.
But we are working with our education partners as well as part of that strategy. So it's definitely worth us feeding that in.
Thank you. Thank you.
And UHI is represented today at this meeting. We have Professor Brian Williams with us, and I'm sure he's taking note of these comments and will be able to feed them back. Indeed, he's wanting to come in now, Brian.
Yeah, sorry, I did recognise, Boyd, you said the final comment. So it's just one sentence, and just say, Carol, let's talk. Very much so. I mean, I came from Napier, where we set up a new physio course over these last few years. Definitely recognise the importance of the benefit of recruiting people, having the placements, including the advanced physio practitioners as well. So I'll be in touch. Let's have a chat about it.
Thank you. Thank you.
My colleagues don't recognise the meaning of the word finally, so lastly, Heidi.
Sorry, thanks so much, Boyd. I knew your heart would stop when I put my hand up, and I apologise for that. So first of all, just to add to my thanks to everybody, Kieran, you did an absolutely fantastic presentation at the Area Clinical Forum recently, and it gave us an opportunity to really understand the applicability of this model to other areas, and to think strategically in terms of how we can use this for other services and other specialities, and thank you. So I think, despite the fact that you're trying to move on to a new job, we'll definitely probably be pulling your experience along with Jude as well. So thank you. So I couldn't not come in, actually, because we've been doing a lot of work with UHI already, and Brian, it's great to have you here, and welcome, and I hope I can get on your orientation programme at some point. It's critical for NHS Highland that UHI plays a part in the development of AHP staff, and we have to have training locally if we are going to survive. So it's a key conversation, and wouldn't it be fantastic to start with physiotherapy? And I'm very hopeful because everybody that I speak to is very open to this. Of course, what we have to do is influence others, and I have conversations forthcoming with the Chief Nursing Officer for Scotland, and we'll set our stall out and see if we can't move this one forward. But great, thank you so much, guys.
Thanks, Heidi. And can I just thank the team, Karen, Jude and Kieran, very much. The fact that we've overrun by about 10 minutes is not down to you, it's down to the interest you stimulated in your presentations. Graham used the word fascinating. That was the one that came to my mind as well. Fascinating and enlightening perspective on what you, the services you provided during a very tough time during the pandemic. So we really appreciate you coming along today and taking the time to be with us. Notice that Karen is ready for action already. And we hope that we will continue these conversations with you. This slot in the board agenda is important because it gives us as board members an opportunity to hear directly from the front line what your experience has been during the pandemic. And we want to thank you again for all you have done for the people of the Highlands during the pandemic and beyond that, earlier and beyond as well. So thank you very much for coming along. You're welcome to stay on if you so wish, but I guess you have other things to do. But a big thank you from the board to you.
Thank you.
Thank you very much.
Bye. Thank you. Bye-bye.
I should have welcomed Katrina Sinclair to this board meeting today, and to congratulate Katrina as the new chair of the Area Clinical Forum. So welcome, Katrina, and congratulations on your appointment. I also should have notified you at the beginning that the meeting is being recorded for future upload to our web, and to remind board members and participants to use the show hands facility, which you've already done, to speak at the meeting rather than the chat function. With that, I think we can move on to, I should have also welcomed members of the media who are with us and also members of the public. Move on now to the minutes of the meeting of the 30th November, and rather than go through this page by page, can I just ask if there are any amendments or corrections to be made to these minutes? Not seeing any hands, can we therefore take the minutes as an accurate record of proceedings of the November meeting? Thumbs going up. Okay, thank you. Moving on to matters arising, first of all, there's the action plan, and I'll just ask Ruth to update us on the action plan. Several of the items on it have been completed, and others are noted for development sessions or for board meetings in March. Ruth, is there anything else to be added?
No, there's nothing else to be added there. Thank you, Boyd. It's fairly self-explanatory. There are a couple of items which we're proposing to now consider as completed and to move off the action plan. And there are just 3 others sitting there, and you can see that they will be attended to within the forthcoming.
Thank you, Ruth. Are there any matters arising from the minutes that anybody wishes to raise at this point, matters that aren't covered in the rest of the agenda? Not seeing any hands up, so we can move on therefore to item 6, which is the Chief Executive's report, verbal report from Pam.
Thank you, Boyd. I have a few things I want to go through this morning. I suppose the first one to just pay attention to and just acknowledge is the Murray maternity report, and of course we have that item on the agenda, so we'll talk more about that when we get to that item. I won't say much about that at this point because we'll obviously be discussing that later. I suppose in terms of our current situation and how things have been in this health and care system in Highland and Argyll and Bute since we last met, is that it has been quite a difficult couple of months again, sustained pressure with staff having to deal with another wave of COVID with a different variant and all the kind of unknowns that we had to operate within during that time. I'm pleased to say, and then Tim will say more about that, we obviously are seeing some easing of the system, although I say that with huge caution, because actually the main impact for us has been the effect on people in terms of being able to come to work and the isolation impacts, etc. Childcare, all the things that happen when you find yourself either contact traced or indeed testing positive for COVID, and there are probably many of us that have had that experience now. It's become more common with Omicron. So the impact has been really quite challenging, and that hasn't stopped for us. So whilst there's been some signs of easing, we still have significant challenges in our health and care system, staffing particular areas, and social care in particular has had a really challenging time in the care homes and care at home. And I guess when you really think about our geography and you think about the size of some of our teams across our areas and our rural areas, it doesn't take, our teams are small in some of these areas, so it doesn't take much to put them in a really difficult position. So I think it's worth just reflecting on that and acknowledging that the pressure is very varied right across the system, but there is nowhere untouched, and we're not out of the woods. And so I want to pay just a little bit of tribute to, as we see out in society things easing, and people are now able to do all sorts of things that were restricted before. The challenge for us in health and social care is that we're not really in that space. And as we try to remobilise, we still have quite a balance of trying to manage the way in which we have to work, which is different due to infection control. And also the staffing impacts will continue probably for some time. So we will try our best to remobilise appropriately, and we will absolutely be trying to get to the right place for people, but that is not going to be an easy journey. And so I guess the plea is that people understand that's the context in which we will be working. So whilst we might be out enjoying ourselves socially and people might be able to do all sorts of things, we are still a very pressured system, and we are really keen to get to a much better place, but we have a lot to address and deal with in that space. So that probably leads me on nicely to, obviously, our strategy development is really important, and we had to pause some of our engagement during this latest wave of Omicron. And therefore, we would ask the board if they would be supportive of us extending the time by which we bring back the draft strategy into July of this year, because we feel it's really important to do it right and to do it well and to engage well with our communities and our staff in trying to set the direction for the future, which is going to be really critical in solving some of our problems. And that kind of relates to what we've just heard from the teams, the possibilities for change, the possibilities for different ways of working, continuing to prevail as we reshape how we do our business in pursuit of the right outcomes for people and being able to deal with people in a timious way, which of course we know at the moment is a challenge for us, particularly around elective procedures. So I'll pause there before I go on to the next couple of items, but just wanted to check in and formally ask the board, because we had agreed a timeline to April, so this would be extending it in recognition of the pause that's had to happen to complete that work and bring forward our draft strategy.
Can I just ask then board members to agree to Pam's plea to defer the board strategy completion to the July meeting? Are we happy to do so? Yeah, I'm getting some indications of assent.
Okay, that's super. Thank you very much. I appreciate that. Couple of items that I wanted to cite you on that are kind of hot off the press, so to speak. So we have been working nationally with colleagues and locally to look at some of our recruitment challenges, and all boards have been asked to look at international recruitment. So I'm pleased to say that we seem to be taking some, I would call it baby steps into that territory, because there is a lot to understand when you move into that space, in terms of working with other boards and working with other countries to look at how we get a new way of bringing people in to work in health and care, and particularly the focus of this piece of work that's going forward now is around recruitment of nurses. And the country that we are looking to partner with is Zambia. So that's a hot off the press idea that's being looked at in terms of feasibility. And as I say, there's always an awful lot to think about in taking these steps, but we certainly as a country are looking much more at at other countries who may have a supply of different professions who would be keen to work in our country and help us address some of our workforce challenges. Some other boards are ahead of us in this, and we will seek to learn from them, but it was just to make sure the board were aware that we will be looking at the feasibility, particularly in relation to the National Treatment Centre, but of course in all that we learn about how we do this, it's got potential for our whole system. So lots to think about, but just so that you hear it here first. And the final thing I want to advise on is we signed off 2 initial agreements to go into government, one for Caithness and Sutherland and one for the Lochaber area. And I'm pleased to say that the Caithness initial agreement has been approved, and that's just hot off the press as well. And we are doing some further work on the Lochaber one and looking to get that in as soon as possible, in the hope that we have a favourable outcome on that one too. I'll bring Alan in just for 2 minutes to advise on what that means and what the next steps are, so that people are clear on that, and then that will be me finished with my report.
Thanks, Pam. And yeah, it's just really good news that we're allowed to progress with the next step for the work within Caithness. So what happens now is we move out onto outline business case. So the group are pulling together a programme to deliver that over a period of time. We did have an initial programme, but due to net zero carbon and NHS Assure, we need to re-look at that and re-evaluate it. But the work's already started. We're doing the place-based reviews, and as some of the non-exec, so Alex sits on the programme board there, so we'll be pushing it on with pace because we think it's a really exciting project and will benefit the people in Caithness with the new change in the way we're going to deliver our services there. So it's exciting times there. In regards to Lochaber, we've been set a task, a couple of bits of additional information which we're working on directly with the Scottish Capital Investment Group. And we've got a series of workshops over the next few weeks that will give us information needed to add to it, and that will allow us to move forward with that, hopefully resubmitting it, looking at the March Capital Investment Group. So just a brief update, but it's all been positive.
Thank you, Alan. Any questions for Pam or indeed Alan on any aspect of Pam's presentation? Graham Bell.
Pam, I appreciate the comments about recruitment and looking internationally. And I know that health services have always had a kind of international perspective to them with staff. I suppose I always have a degree of disquiet when we're taking staff from countries that are struggling themselves, often to meet their own staffing requirements. And I think as a wealthier country, we are also obligated to be really pushing hard at what we've talked about earlier with, you know, growing our own locally and making these, you know, making you know, good alternative ways of developing staff and encouraging young people to stay local and giving them the option to do that. So I think it's important that we don't take our eye off the ball of the, you know, the real focus on pushing hard now to grow and develop our own staff. Thank you.
Yeah, I think that's absolutely right, Graham, and absolutely, this is not a substitute for that. This is something that's been explored nationally in terms of how we take this forward, and there is also the whole ethical aspect of this to ensure that if we do engage in this, that we are, you know, really working through the ethical side of this as much as the practical side. As I say, there's a lot to think about when you enter this space, but it's absolutely something that we have been asked to take forward and actually have received some investment to be part of. But you're right, we really want to have many routes that in a local context that can allow us to grow our own as well. Fiona might want to add. She's been obviously alongside this.
Yeah, and it's a really good point, and I think just to reassure that that there are very strict kind of guidance and rules around the countries that we can and will engage with to ensure that we aren't depleting countries that don't have a ready supply. One of the areas that we've been taking forward actually are in the opposite position, in that because of investment over the years in training nursing staff particularly, a number of these people actually can't find opportunities in their own country and are doing non-nursing work. So that's a key point for us. I think it is about, as you say, this is a sort of short to medium term fix to help us catch up with that sort of skills and experience gap in the longer term. And as Pam highlighted, for a remote and rural board like NHS Highland, working across the Highlands and Argyll and Bute, we need to put even more support and structure in place for people, you know, relocating from anywhere in the UK, but particularly from outside the UK. It's quite a different proposition for people to, you know, to maybe come to the Highlands compared to coming to Edinburgh or Glasgow. So that we're being very cautious about that, because when we do bring people over, we want them to be happy and to be settled and to stay with us.
Thank you, Fiona. Alex.
Yeah, thanks, Boyd. Yeah, to build on Graham's point, Pam, is this a reciprocal arrangement? Are we doing anything to assist them with training or equipment, or how does it work? Or is it just that we're just standing with our arms open, go, come and help? How does it work out?
Yeah, well, quite often how it works is that these people are already highly trained, but there isn't jobs for them. So when I worked elsewhere, where we had a partnership with Australia, it was because there was a huge supply of nurses with no jobs for them. So the partnership was to bring them in. So we're very varied. I probably just want to emphasise this is very much in the very early stages of exploration and discussion. So there is not, you know, people arriving next week to work for us. We are working with a board that's already ahead in that kind of partnership to understand what the possibilities are for us. So we're at the feasibility stage of exploring the potential and how we could even test that. We're quite a way off from having a supply and lots of people coming in. There is a lot to consider in this, and we will be taking cautious steps to ensure that if we do this, we do it well.
Thank you, Pam. I know from my experience in education that this also happens in education where there's an over-provision of teachers in one country, that Scotland recruits from Ireland, for instance. But I do take the point that Graham has made about the ethical aspect of this, and also Alex's pertinent point about reciprocity. And if there's anything we can feed back into Zambia to help the Zambian situation, that would be very welcome, I think. Any other points? In which case, We'll move on to the next item, which is the public health report, and invite Tim to speak to the report and make a presentation.
Thank you very much, Boyd. I will try to do the presentation myself, and hopefully it will come over adequately, so hopefully members and others can see this. There is a brief paper with that is with the other papers on COVID. One of the features of COVID over the years it has been with us now, it's interesting to think that it's called COVID-19 because it first came around in 2019 and we're now 2022. Even though most of the effects in the UK didn't start until 2020. One of its features, though, is its fast-moving and to some extent unpredictable course, and I think we need to be conscious of that, but also that it can be difficult to say very much in advance, and so the presentation contains up-to-date information as of a couple of days ago. First of all, just a few comments around the background and issues on rates and testing. We've got good testing facilities now, given our geography, and reasonably widespread access to PCR testing. But the move nationally has been to increase the proportion of lateral flow tests, as lateral flow tests themselves are very accessible, and also given the prevalence of COVID and also the increased quality in lateral flow tests, they're becoming a better way to judge infection, and certainly it's unusual for people to test positive on lateral flow and not to have COVID, given the high rates. What that does mean, though, is that sometimes the figures can be a little more difficult to interpret, because lateral flow tests don't just need to be taken, but they also need to be registered on the national system in order for them to show up, and that is shown in one of the later charts. What I'm pleased to say is that, as is widely noted in the local and national press, rates of COVID are certainly showing an overall decline, and that is good news, especially with children going back to school, that we might expect some degree of an increase, but that hasn't really happened. However, we do still face very considerable challenges. We have outbreaks in schools, outbreaks in care homes, and the new variant is by far and away the most dominant variant. What we haven't seen is a great rise in people who are seriously ill, and the impact on cases coming into hospital and cases in intensive care has only been moderate, but there's a huge impact, as has already been mentioned, on staffing, with people needing to isolate and people testing positive, and that's particularly profound in social care, care homes and care at home. Just to give an idea around the numbers of cases and how that links to tests as well. This is a brand new type of chart which is available publicly on the Public Health Scotland Tableau website, which looks at both PCR tests and lateral flow tests. The lighter purple is PCR, the darker purple lateral flow. And you can see over the course of January that by and large the numbers testing positive has shown a decline, and the chart for Highland is really quite similar to the chart for the whole of Scotland, but also the numbers and the proportion of lateral flow tests have increased. We're at the absolute peak, we were seeing around 900 PCR positive tests, and I think on our worst day, well, in fact, a bit more than that, just shy of 1,000 PCR positives. We're now seeing somewhere between 100 and 200 a day PCR positives, but we're seeing about the same number of lateral flow tests as well. So we're still seeing a very considerable number of COVID cases, but it is going down. And the other good news around that, when we consider PCR and lateral flow tests, is that where people have symptoms, then they're asked to take a PCR test. So lateral flow tests are really positive. We'd expect most of them to be positive for asymptomatic people. So while we're still seeing large numbers, quite a proportion of those will be testing and that they'll be asymptomatic, needing to isolate, but not showing the symptoms, and so that has then implications for good implications for health services. If we have a look in across the geography for Highland and Argyll and Bute, we see a similar pattern. It's numbers on the left and rates on the right. We'd expect the Argyll and Bute numbers to be smaller, but we see a similar pattern. These are just PCR tests, but a pattern of a very considerable increase at the start of January, and then a steep decline followed by a bit of a slower decline. So we mustn't be complacent, but certainly this is good news. When we look at age, one of the features of the Omicron variant and the real upsurge we've had over the past few weeks has been, it's really been predominantly in younger people, so people below 25. It's not just younger people who got Omicron. I've had Omicron a couple of weeks ago, but predominantly it has been much younger people, and we're seeing the outbreaks in schools at the moment in primary rather than secondary. But this chart shows with cases in January that the age is a bit more spread out now. The peak age is late 20s, so we're getting a bit more Omicron in the whole of society. We're seeing a bit the virus throughout the area of NHS Highland, slightly more in the more built up and urban areas around Helensburgh and Inverness, but overall we're seeing a decrease in cases across the board. So the chart on the right is up to 14th of January, and the chart on the left the following week up to the 21st. So the lighter colours show a bit less COVID. So not very, very dramatic changes, but certainly consistent changes across the whole of the board area. If we move on to vaccination for the country, getting very good coverage of all three vaccinations, including the boosters. The start was slow. We were plagued with poor communication, but that has gone an awful lot better. And we've got a great deal of enthusiasm. There's been very little activity of people against vaccination, and the great majority of our citizens have been really keen to get vaccinated, and we've had a great deal of support across the board, including staff employed by the board who have been working differently and working additional hours to take vaccination, but also support from general practice, other parts of primary care, volunteers coming in. We've had excellent support from the army as well. People can still get vaccinated even if people are completely unvaccinated or haven't had a second dose or haven't had a booster. We've got information on the board's website, but at the moment our focus is moving to children and young people, making sure teenagers are vaccinated, and also we're moving to vulnerable 5 to 11-year-olds, which will be starting soon. And we're also planning for further vaccinations within the next financial year, both in terms of plans for COVID vaccinations and also implementing changes to the overall vaccination programme for the board. If we have a look at board coverage for vaccination, I think this is a slightly busy slide, so I apologise for that, but I think it's a very good one that demonstrates coverage in age groups. Essentially, the darker the colour, the more vaccinated people are, or the greater proportion of people in that age group that are vaccinated, and the darkest blue shows 2 COVID vaccinations plus a booster. So in all groups, we are all groups over 60. There's over 90%. These figures are a little bit old, so I think for everyone over 40 now, it's 40 to 49 is now 80% booster. So there's a really good coverage, and then we're working on the to increase uptake in the in teenagers. If we look at our comparison with other parts of Scotland, you can see we're doing pretty well and on a par with other similar boards. And also, if we look at how we're doing to make sure that the more deprived people in our communities are also getting vaccinated, while there is a difference, as we'd expect with most things in terms of vaccine coverage and deprivation, there's still reasonably good coverage even in the most deprived communities, and our gap in this regard is considerably less than for the most than for most of Scotland. So there's still a bit of a way to go overall with our vaccine coverage, but it has been a really successful programme and is to a large extent responsible for the for what we've seen with the effects of the Omicron variant, and how while it has had effect on staffing, it hasn't had a huge effect on people's health. So a range of measures, but mostly vaccination, have been really effective. I think that will be enough for the presentation, and I'd be happy to take any questions, and I shall close that.
Thank you, Tim. Just one question, Tim, about the absence of flu this winter. Have you any thoughts as to why that has happened? Is it directly linked to the COVID situation?
Yes, I mean, I think it's been remarkable, really, for the last 2 or 3 years how little flu there's been. There are several reasons that have been proposed as the reason for that. At a local level, the precautions that have been put in place because of COVID, social distancing, wearing face coverings, isolation, they'll have had a huge effect. But also, one thing to bear in mind around flu is that it spreads around the world, that there are waves of new flu variants and new flu mutations, which change slightly every year, and they move around the world. So one of the factors in terms of flu is actually the reduction in international travel, and the low levels of flu have been seen internationally, and we're still at really at baseline levels for flu across the whole of Scotland and wider areas as well. One thing to say, though, to give assurance to the board, is should we get an upsurge of flu, which is unlikely, very unlikely, but still just possible, we do have good flu vaccination rates. We're up to about 79% for eligible population, against a target, I think, of 80. The programme has, for the wider population, been suspended by the Scottish Government so that everyone can concentrate on COVID vaccination. But as I say, we're up to 79%, which is actually higher than last year.
Thank you, Tim. Deirdre, followed by Alex.
Thank you, Chair, and thank you, Tim, for your report. In terms of accuracy of understanding, do we have an insight into the percentage of LFTs which are recorded?
I think I'm afraid the short answer to that is no, because they are very widely available. So it is very difficult. And what that also means is it's becoming increasingly harder to interpret some statistics. So what we used to say, for example, was we used to have a look at the percentage of PCR tests that were positive and use that as an indicator of how widespread infection was in the population. And the World Health Organization set a threshold of 5% as indicating that there was widespread population spread of COVID. But we could only do that because we know how many PCR tests are being taken, how many are positive and how many are negative, and we just don't know how many lateral flow tests are negative. That also affects the PCR tests because now people are only using PCR tests when they're symptomatic. That's which is the right thing to do because a negative LFD is difficult to interpret and probably doesn't mean a whole lot. Positive does, but a negative doesn't mean that much. Or certainly one-off one. So it just makes things a bit harder. And also we try to distribute LFDs as much as we can so that people get the opportunity. So we're starting to distribute them in vaccination centres. They've been available from pharmacists for a long time. The local authorities are distributing them. We're having additional targeting distribution. So I'm afraid it's just it is very difficult. But we are working to try and make sure that as many of people register LFDs as possible, both positive and negative. But the really important thing is to register one when you're positive, because that's the only way really that can feed it into the system.
Thank you, Tim. Alex, followed by Joanne.
Yeah, thanks, boy. Yeah, Tim, the group that we're shielding, the more vulnerable in our population, are they getting a fourth injection? Is that something that's planned? Because you hear bits about it and then it sort of all dies a death. And I'm not sure what's happening. Thanks.
Yeah, thanks. There is a slightly semantic difference, so just to cover briefly. There are a range of people who are shielding because of increased vulnerability. The group who would get a fourth dose are those with a particular level of immunosuppression. So I think pretty well all of those would be shielding, but there are people who are shielding who would not fall into that category, if that makes sense. So those who have an additional, who have a certain level of immunosuppression, the first two doses don't give enough immunity in many of those people. So they have been given, instead of a booster, a third dose. And it's confusing for many people because it's the same vaccine given at the same time as a booster and many of the same clinics, but it's being called a third dose. So the 3 doses aims to give an appropriate level of immunity for those people, and then subsequently they have a fourth dose which acts as their booster. And so we're in the at the moment we're in the middle of that program of delivering the boosters or fourth doses for people who are immunosuppressed.
Joanne, followed by Gaynor.
Thank you. Tim, I wondered if you could tell me if we're doing any recording of the stats and trends for long COVID, thinking forward in terms of implications on staff and services.
I haven't got that information with me. I'm not. It'll be a little bit of speculation that around exactly what we're doing. So I'll need to take that off, and we can report on that. It's something that's important, but it is quite a challenge given the different elements of long COVID, both respiratory that were talked about earlier on, but also there are a lot of post-viral elements of long COVID, which are causing quite a lot of illness and debility, and it will be difficult to capture them. But I'll need to come back and an update outside the meeting for that, I'm afraid.
Thank you, Tim. Gaynor, followed by Anne.
Thank you. Thanks, Tim. Thanks for the update. I just wondered if we were seeing any correlation between the reduction in infection and transmission in secondary schools linked to the vaccination of young people and the quite good uptake that we've had, certainly for a single dose, which was offered first to young people, or if it's a bit too early to say. Thanks.
Thanks. It could well be. I think it's. I think it at the moment it will be a bit of correlation rather than causation. So I think that there may be a difference. I think it's probably an element of that, but also perhaps an element that at secondary school a lot of the young people will have picked up the Omicron variant earlier, and increased socialisation around Christmas and lots of asymptomatic infections may have had more to do with it. So I think it's probably a mixed picture, but I think it's likely that there will be an effect of that. But what we're seeing certainly for older people is that really the best effects come from the 3 doses, the 2 and the booster. There will be a protective effect from 2 doses, but the protection is mostly around getting illness rather than transmission. So I think you're right. I think there will be an effect, but it's quite difficult to quantify at the moment, and we're likely to be mixed with lots of other effects too.
Anne.
Thanks, Tim. I was wondering if there has been any sort of significant learning from our recent experience of vaccination that would suggest we need to adapt our strategy in any way, and what are the next sort of critical steps in terms of further implementation of our approach to vaccinations? Thanks.
Yeah, there was certainly a lot of lessons that we have learned around the approach to vaccination. Probably communication certainly a key one, and getting proactive communication and early explaining what we're doing. Also taking a locality approach is probably the other principal learning point that we've got, and we are in the middle of the national vaccination transformation programme, where we're looking to move the vaccination from a more primary care based settings, in the most part and not entirely, to board delivered services. And we've seen how people value their local services, and how the local elements of the services can be different in different places, but can still be effective. In terms of the critical paths, we have programs, as I mentioned, of COVID vaccination, which will come up within the next financial year, and we have the transition of other programs. So we are through the newly established vaccination program board, looking very carefully at, but also very quickly, at how the programs will be delivered, and also learning the lessons from delivering board-led services, initially in places like Lochaber, but subsequently more broadly, and about how things work, about locations, about staffing, and there are a whole lot of tasks that need to be done, such as recruitment, establishing the balance of primary care versus board delivered services. So there's a huge amount of work being done over the next few weeks.
Okay. Any further contributions? If not, we're being asked to note the report on the presentation. The board's been invited to take moderate assurance from the report. Are we happy so to do? Okay, thank you. And we can move on now to, before we move on, in fact, to the next item, can I just thank Tim and his team for all you have done and are continuing to do to lead the public health effort in response to COVID. We'd fully appreciate, Tim, that your team has been really under the cosh in this regard for a very sustained period. As you said, COVID-19 is still COVID-22. And we want to thank you on behalf of the board, and if you could express our thanks to your colleagues in your team for that.
Thank you, Boyd. Now I will pass that on.
And we move on now to the next item on the agenda, which is to do with maternity services and a report that was commissioned by the previous Cabinet Secretary into maternity services in Moray. This report has implications not just for Grampian, NHS Grampian, but also for ourselves in Highland. You have a paper prepared by Catherine about this topic, and there is also a letter, copy of a letter to the Cabinet Secretary from leaders of the team in maternity in Rigmore, expressing disquiet and concerns about the proposals, one of the proposals at least. This is all against the background of the fact that the report has not yet been published, and I'm going to ask Pam initially to make some comments.
Thank you, Boyd. Yeah, really important topic for us to be discussing today, and to really set the context of. So the status of the report is that we are still waiting for the Cabinet Secretary to formally advise on his endorsement of the recommendations or not. So today's conversation is taking place in the context that this report came out before Christmas. With the set of recommendations with implications for us, and I felt it was really important that as a board we had the opportunity to discuss those implications and take any questions that people had in and around what this might mean for us if it were to proceed. I think the purpose is then for us to have that kind of, I suppose in some ways it'll be at this point a fairly high level discussion, because should this be the recommendation that we're asked to pursue, it will require significant detailed work in terms of delivering a target operating model, and in terms of bringing forward a business case through the board that people are comfortable with. And of course, central to that has to be where our team is at in this. And the last thing I probably want to acknowledge then is that obviously there has been the letter that has been sent to the Cabinet Secretary by our team expressing their concerns and some risks that they are raising that need to be duly considered and worked through with the team. I think they were very clear at the end of that letter that they were keen to work with us to deliver this, and that's indeed what we would need to do. And I suppose the emphasis that I can't maybe put out there strongly enough is that first and foremost we have to have a very clear way forward for Highland maternity services, for the population of Highland, and to look at and review the models we're delivering currently and whether they are fit for the future, and what else we would need to do that could improve and ensure that we are delivering the best outcomes in line with Best Start for our mothers and their new babies and their families. And we know that in Highland in itself there are concerns about that as it stands, and therefore that everything we do here has to be done within the context of the wider picture for NHS Highland. The Moray component, if that is recommended, is a component. It is not the Highland maternity strategy, so we need to keep it in that context. And probably the last thing I want to say on that is that clearly I've heard in the media, I've seen in the media the kind of reference to overcrowding that will be caused by this. I want to give assurance to the board that I've been absolutely crystal clear that that will not be the case, because we have not signed up to any model that has not addressed the environmental issues that would need to happen, the space, the fitness of the environment, and actually we have issues that we need to address there anyway, to be fit for the future, and that there's appropriate staffing and configuration of staffing and funding to support that is in place, and indeed the ability to recruit. And the 2-year timeline that we put in as an estimate was really based on the pipeline for recruitment and what we know, when we know there will be a greater availability of midwives. But the assurance I'm trying to give is that we have not, if we were asked to deliver this today, we could not. That's absolutely not the case. We could not deliver this within our current environment and with our current resources. And I've been explicit about that. Cabinet Secretary has accepted that. We would need to be in a quite a different state and within the context of our overall strategy. So we will work through that with our teams, with our communities, with our Highland maternity voices, with other groups that have an interest in this, to look at our Highland context and to then to look at what the Moray aspect is within our overall service. And we will address the environment if this is the way forward. We will have to anyway. And we will also have to recruit to the level that makes that a safe and high quality service in line with Best Start. So I feel it's important just to set that out, because it can get quite lost in translation, and it's very difficult sometimes to get all that communication out as clearly as we would want to. I'm actually going to hand over to Catherine to say a few words, as this is obviously a service that sits within her portfolio, and I think Boyd and Heidi may well want to add to that, but happy if you want to take questions before we move across, or if we want to finish saying what we have to say first. Leave it with you, Boyd.
I think we'll ask Catherine to comment first.
Thanks, Boyd, and thanks, Pam. I think it would be useful for the board also to understand that as a part of bringing forward the acute structure, we now are accommodating community midwifery services under one management structure, and that's been an aspiration within the Health Board for a very long time. So we're now in a position to be able to do that. And Pam's absolutely correct. For some time, the board has been working on the delivery of the national specification in relation to Best Start, and you'll see through the paper that you have in front of you that there has been a number of investments in terms of infrastructure that are have either concluded in terms of the Caithness building and the community midwifery unit up in Caithness, but also that's proposed in terms of the Belford rebuild and improved maternity facilities there, and also proposals for a community midwifery unit in Invergordon. More challenging for us is the infrastructure within Raigmore, and that's something that, as Pam has noted, is something that as a health board we know we have to take forward. In terms of delivering the Best Start for Highland, again, the workforce is absolutely critical to us, particularly around midwifery services. And we know that there are challenges in terms of the sustainability of the workforce models to deliver across the Highland geography. Within the hyper-acute setting, shall we say, of maternity services within Raigmore, we have challenges both within the physical infrastructure, but also particularly within the workforce. And those workforce challenges are particularly at sub-consultant grade for obstetric staff and also for midwives, as we try to increase the capacity within the service to deliver our own NHS Highland service. So we are engaging with the teams. We're really acutely listening and keen to hear what our teams have to say. It is unfortunate that they feel the way they do feel at the moment around the engagement with the report that has been put forward. And indeed, I'll be leaving the board meeting this afternoon to meet with the team and discuss further with them how we start to move things forward. We do have a strategic plan in terms of our engagement strategy with the team. I, as a part of picking up the entire maternity service across Highland now, will be establishing a maternity programme board that will ensure that we can provide governance, leadership and direction to moving maternity services forward for NHS Highland. This maternity programme board will ensure that it covers the elements of organisational development across the area, communication and engagement, and also infrastructure, physical space, and ensuring that we have the right financial infrastructure in place to deliver the service for the future. And as a part of that, obviously, we will be looking to accommodate the aspirations of this report so that if it is approved by Scottish Government, we are in a position to understand what the implications are for our own workforce here in Highland. There are some recommendations in the paper that's been presented, and I would ask the board today, Chair, to endorse those recommendations as a way forward. So happy to bring Boyd or Heidi in at this point should they have any further comments to add. Thank you.
Should maybe hold that just now and ask Heidi and Boyd to come in response to any of the contributions and questions. Gaynor.
Thank you, Chair. And thank you, Pam. I think that was really important that you highlighted that we have the Highland maternity model to work on, as well as any future model as to what's happening in terms of how we can help and support Murray. And just kind of based on that, I have a couple of questions. The first around the Highland model. So in my head, it seems that if you were a mum on a red pathway, you'd be most likely to be going to Regmore maternity unit. And if you were on a green pathway, you would have the opportunity to go to a CMU. In the report that we have, it talks about CMUs in different locations. And I just wanted some clarification. There's the New Craig site was mentioned, as well as the Invergordon Community Hospital. And a phrase was used called an alongside CMU. And so just to clarify which is the New Craig's, the alongside CMU, or is the alongside CMU expected to be on the Regmore site? And just in terms of Invergordon, do we have an evidence base for having that in Invergordon in terms of how we see population growth rising in the future, in terms of are we expecting a particular population growth in Easter Ross that would, you know, make that a good strategic place to have that? And my final question linked to what we're doing in terms of, or what might happen in terms of the Murray model, is really just to get some clarification on what we're currently doing to support delivery to mums in Murray. And in terms of these recommendations, it seems that the biggest risk, even potentially to the Highland model, is within staffing and a built environment. And we've recognised that, I think, for a number of years, and are working to address that. But do we know where we need to get to at the moment in terms of how we fix that? I think we do in terms of the Highland model, but if we do have to go with the recommendation and are asked by Scottish Government to take on the Murray model, the Model 4 that was outlined, do we know where we are in terms of additional capacity, both for staff and for the built environment, and timescales? Thank you.
Okay, I see Heidi's hand is up, so I think maybe Heidi, if you want to respond to some of these points.
Thanks, Boyd. Yes, I'll pick up the first couple and then happy to continue, but Boyd or Catherine might want to come in then. I just wanted to respond to your question about the community midwifery and maternity units and where they were and what function was going to be placed where. So just to sort of clarify that for you. In New Craigs on the Claver site, we are introducing a maternity hub. It's a community maternity hub. It's not a community midwifery unit, so we won't see births there. But we will see women there for their antenatal clinics, for example, and that will be a fantastic hub for the midwives. So we're developing that. In the alongside CMU that you talk about, that would be in Raigmore if we proceed with that one. So the advantage of an alongside CMU, I think personally, is great, and it's something that we've been wanting for a number of years now. And basically it's a place where women can give birth. It's less clinical, it's a more homely environment. We don't expect major medical intervention at all. But because the unit is so close to the obstetric unit itself, if an emergency should occur, it means the women can be moved very quickly into an area where they can be cared for appropriately. And of course, women feel safer in that environment. And the evidence is that people will very happily use that environment. So we would expect that to be used by a lot of women. And of course, what that does then is reduces the pressure on the acute unit, which, as I'm sure everybody knows, is quite small. So that leaves Invergordon then. And Invergordon is a site that we've developed as a community hub, much like we're planning to develop Carver Ward. So this is where we have midwives based. They see women there. They see them for antenatal clinics. They see them if the women have any issues like raised blood pressure, etc., before perhaps referring on to Raigmore. And what we've again wanted to do for a number of years is to develop that to a community midwifery unit where we would birth, where women would give birth. The reason why we've chosen that spot is not so much to do with population growth, but actually population density. So it is in between sort of Golspie and Inverness, and we believe that women who certainly use the hub at the moment, a proportion of those would definitely use the CMU. We would predict probably about 10% of the population would use that as a community midwifery unit, and that's, as I say, because of the density of the population, the age profile of the population, the number of women that are going to get pregnant, etc. So that's sort of answering your first and second questions. I'm happy to hand over the others though to my colleagues.
Catherine, do you want to know?
Yeah, can I just check, Gaynor? I was trying to write down as you were running through all of that, what's outstanding in terms of what we haven't responded to?
Sorry, yes. Really just to get a feel for the picture of what we're currently doing to support Murray. And if we do move into the point where Scottish Government asks us to take Model 4 forward, I think you've already outlined the staffing and the building capacity, so the staffing capacity and the issues with the built environment. But are we sure that we can get to where we need to go, I guess, in the timescales that are kind of outlined in the paper, so the 2 years? So would it be, so I suppose what I'm not clear on is, would we be asked to take up this model maybe in the next 6 months, or would we be asked to work towards it in the next 2 years? And then for how long?
Yeah, thanks, Gaynor. So On the first point, what is the pathway at the moment? At the moment, for ladies that are opting to deliver their babies in Dr. Gray's, for any mothers that perhaps may get into difficulty as a part of that, and the midwives don't feel confident to continue with the delivery in that setting, they would contact the Regmore unit, and we would look to transfer to support that lady's delivery. So hopefully that clears that one up. In terms of you know, the timescale question, there's a lot to work through, Gaina, in terms of this, and we need to work with our teams, look at what the potential options are for service delivery and for development of the workforce locally. And the teams actually do have some thoughts about how we might be able to address that. From my perspective, we would not be progressing with moving forwards with anything unless it is absolutely safe to do so, and the clinical staff are confident that we're not introducing risk unnecessarily into our Highland system. So it's just to be clear about that. Hopefully that helps.
I think Pam may want to come in as well.
Yes, please, thanks. I think there is no doubt that the situation with the concerns, you know, for Murray women will continue to probably put pressure to try and move more quickly. But that's the reason I've set out our position as explicitly as possible, so that we retain clear lines of demarcation and an ability that if we go down this route to deliver it well. I guess the 2-year timescale is an estimate based on midwifery pipeline. We would have, you know, there's a whole host of staff involved in this, and there's a whole host of moves. So I think that in itself may put a limitation on that, but we need to test this out. We need to test out further with the team and with partners such as Scottish Ambulance Service, etc., in terms of what does this pathway really translate into, and how would we make that work, and do that diligence around some of the assumptions. And in terms of the environment, that's probably the bit that's the easiest to answer. That we've got a good idea, thanks to Alan's a previous experience and the work that he's done on what we would require. And we also know the cost of that, and in some ways doing the environmental work, which would probably be the first thing you would do, is fairly straightforward. And I don't know the timescales for that. I don't know if Alan wants to put a timescale on that, but that would probably be something that could be done and completed. But the real challenge here will be agreeing safe, best start based practice and pathways, and getting the appropriate staff in place, as is the issue in maternity services right across the country, actually. And it's not just maternity, it's paediatrics, it's neonatal, it's all the interdependencies that need to be connected. So we've got some real diligence, and that's the reason for a programme approach. And even if we don't find ourselves in the Murray situation, if that were to be the case, we still need to do that. To review where we're at and where we're going, for sure, and that would be the plan.
Boyd, did you want to add?
No, Chair, although we're getting into lots of detailed questions, and many of the details, I mean, some, as just asked, are operational, how it works currently. But for the board particularly, I suppose the key thing is, what's the process? And how will we address everything? And it's particularly for the board to be mindful that the biggest issue for us is to improve our maternity services. And as the medical director, I would also introduce or remind that that includes neonatology, so the paediatric side, looking after the baby when it's been delivered, because some deliveries result in a baby that needs expert help in the right sort of unit, and that's part of the package. So I think the fundamental question for the board, amongst all of the detailed questions, has to be, what will our process be to build maternity services in Highland? The subsidiary, although that's why we're discussing it today, is what will government ask us to do in terms of supporting Murray, since we will be part of a network of maternity services across the north of Scotland, and that's almost a subsidiary question to the main issue for NHS Highland, which is developing, promoting, recruiting, building the service and the facility that we need for the future, and which makes services safest for all of the requests and all of the clinical pressures that we will have in the future to deliver here.
Thanks, Boyd. And just to remind colleagues that there has been no decision taken yet by the Cabinet Secretary. We are still at this pre-publication stage. We have half a dozen people wanting to come in. Alex?
Yeah, thanks, Boyd. Yeah, and I was glad Boyd said what he said, because I was getting concerned that we were getting into the weeds long before, we want to keep it up. And in that basis, again, glad that Pam said we've got to protect and look after our own ladies and babies in Highland, and that comes first. The opportunity I can see is that actually I don't think 4 is going to happen, because I think we're going to run out of time. I think 5 is where it's going to go, and we're going to be involved anyway. So we need to make sure that our unit, whatever you want to call it, is sufficient for our needs, and then tag on the other bit. In that terms, have you got a feel for the kind of size of unit? You said Alan's done some work before. I mean, you talk in the paper about 1,900 births a year in Rigmore. Is that the aim? Is that what you're going to build it for? Or are you going to build it for a bit more to make sure that we've got sufficient space, if you know what I mean? That.
So I'm probably going to ask Lorraine to come in and comment, because she's looked at the detailed numbers. And I suppose just in principle, we would be doing a prediction on what we thought our birth rates were going to be, and therefore trying to ensure that what we have is fit for a period of time, I suppose, recognising that we also want to look at the future of Rigmore in terms of what it needs to be. So Lorraine, I don't know if you have anything to add in terms of the numbers, because I know you scrutinised them pretty well.
Yeah, we've obviously taken the capacity and demand, and we're working with Alan to make sure that is fit for purpose, but also taking into account the choice of women and where they want to deliver, and making sure that we've got enough capacity in both units to accommodate that choice as the principles of Best Start. So we will be working on that more fully through the programme board, and getting that detail, like Boyd has said, for neonatology and any other services that need to go along with it. So we'll start to develop that and come back with that through the programme board that Catherine's chairing.
Okay, thanks. Alistair?
Yes, thank you. This is an exceedingly complex issue. It would be hard to find a more difficult issue that's got repercussions on it. And throughout, we've got to take our staff with us. We have to take staff from another health board with us. We have to take the women and families with us, and we have to take the wider public with us on all this. And it is very, very complicated. It's about the option 4, which is up to 2 years to put in place. So option 5 is quite a long way away. And what I'm finding it difficult to understand is the assurance level on this report is moderate. And what would have been useful to me is to get some more insight into the assurance around the journey from option 4 to option 5, and also the complexities around it, with the logistics of people actually getting to Rigmore around that time, and also the clinical side of it. I welcome Boyd Peters' comments. I thought they were useful, and I think we as a board just need to be assured that what is being proposed is actually doable, viable, medically safe, and the right thing to do, or whether I don't know who's on the Murray Maternity Service Review, whether there should have been, there were 6 options there, whether we should have been pushing for a different option, because as has been said, we've got to deliver the maternity services across Highland that are going through a bit of a transformation anyway. We've got this coming on top. We want uniformity across it in terms of service delivery. So perhaps a little bit more information around the points I've made would help me. We know we've got challenges around the buildings. We know the staff have got concern. We know that the women have got concerns. So there are so many stakeholders in this, and at the end of the day, people just want a service that is safe, reliable, efficient for what should be the happiest moment of their lives. Thank you.
Thanks, Alistair. Boyd, you've got your hand up. Do you want to come in?
Yeah, I thought I'd probably take this one. So I think the first point, and well made points, Alistair, around assurance. Well, first of all, we don't know what the government's chosen yet. And so today is really getting the board tuned into the fact that a maternity report has come out, that it will affect what I've already referenced, which were our own plans for what we in Highland wanted to do anyway. There may be some synergies and there may be some advantages to having this, as well as our other stuff that we wanted to do to improve services. So that's the first thing. We need to get all of the concerns, the questions, and the requests for assurance into the process. And that is the key thing. We must, it's right for people to think about all the possibilities and to think about all of the concerns and to identify all of the real or perceived risks. We then need to get those into process and address all of them. The government will be mindful about what it wants for Scotland, and it will look at Scotland not as health boards with finite boundaries, but it will look at Scotland as Scotland and people in Scotland as all being equal. That means that we will need to think ourselves perhaps beyond our health board boundaries, because these are artificial entities and they do not put the patient first sometimes, and they can put patients at risk if we are wedded to board boundaries. Therefore, we have to, in moving forward, build services that are as safe as possible and reduce risk for as many as possible. We also have to support Best Start, and for information to all colleagues and listeners, Best Start is a vision and strategy for maternity services, and it effectively means that people can put in choice, and that means that people can choose where they want to deliver in advance, and people in Murray can choose to have their delivery through Raigmore and through Inverness, and that is a choice that can be made. So allowing choice means we have to have flexibility in our systems in all units across the north of Scotland. We also need to think about, as Highland, we manage risk for people that are at a great distance from our specialist centre in Inverness. And actually, in the grand scheme of things, Murray is actually closer than many of the outposts that we have to support already. And so the question ultimately is about what's safest for mothers and babies in the north of Scotland. And there are times when the risks, the clinical risks, which you've asked about, are such that if a local delivery in and around Murray and in Elgin cannot happen for clinical reasons, then it is effectively half the distance to one specialist centre over another. And so in many cases, the time factor means that the safest option will be to go the shorter distance to the specialist service. We can't change the geography, but what we can do as a board and as a big team of clinicians and all those who support them, we can put in place all of the things that we require to make those risks as minimal as possible and to allow for the patient flow that may come about because of clinical decision making and risk management for those mothers who find themselves in those circumstances. I hope that's a helpful contribution, Chair.
Thank you, Boyd. It has been useful. Anne, followed by Philip.
Thanks, Boyd. So I have a couple of questions and then a comment. So just picking up on Boyd Peter's suggestion that we also need to focus on our services in Highland. I noticed in the Murray report that there was an estimate that the CMU might handle 20% of deliveries in Murray. I understand, or the last figures I saw, that the average for our own CMUs was perhaps around 10 to 12%. If that's still the case, I just wondered whether this should be an aspiration for us, for something that we should be trying to work towards within our own maternity strategy. And the second question I have relates to, I suppose, the assurance that the process that will go on around this can give us assurance. So I just we had an internal audit report back in the end of 2019 on the Best Start arrangements, which raised a number of concerns about the programme board and the capacity that we had to deliver the programme. So I just wanted clarity as to whether the Maternity Services Programme Board referred to in the paper today will be replacing all of those arrangements around Best Start, and whether we've addressed the resource and capacity issues around delivery of that programme, because I know that it's been very difficult and a lot of it has been paused during COVID. So I think we need to have some assurance that all those issues that were picked up in that audit report will not apply to this process going forward. And then finally, I think, whilst I agree today is not for the detail, and this is about agreeing a process, I think that Pam's comments at the start in terms of the clarity that she has provided around our expectations about what needs to be addressed before we could implement any of the models, whichever one the government deems appropriate, needs somehow to be acknowledged or recorded in our approval of these recommendations today. I appreciate that might be a bit difficult to work out how to do that, but for me, I think that was a very important statement from Pam, and somehow our acceptance of these recommendations have to be on that basis of that assurance that she's provided us, and that needs to be recorded in the minutes of the meeting today. Thank you.
Thanks, Anne. I think Boyd and Heidi are both prepared to come in and respond to that. Can I go to Heidi first?
Thank you, Boyd. So just Anne, to pick up your query about CMUs, and as part of our board-wide services, could we aim to increase the number of ladies who choose to give birth at the CMUs? We've got a number of CMUs across the board. So it's not a straightforward answer. The average is about 10% delivery in our CMUs. And there's no doubt in Scotland there are some CMUs that see a higher rate than that, but others that see a lower rate. So we are on the bottom end, if you like, of normal and average around CMU births. What does impact on CMU births is the distance to travel, of course. And if you have a very long distance to travel, that can impact on the level of risk that women and midwives are prepared to take. And so that impacts, I think, and is if you like, an influential factor. The other thing as well that influences us in terms of how many women can give birth in our CMUs is the complexity of the women too. It's the any issues that could move them onto a red pathway. And so there are certain areas in the board where we know that there are more people on a red pathway, and therefore that could and does indeed influence the number of women that will give birth locally rather than women needing to give birth in Raigmore. So I think in terms of the first part of that question, the answer is yes, we would really like to aim to increase the number of women that give birth in our CMUs, and I think we do that work on a fairly continual basis, although the number has been fairly consistent over the years. But secondly, there are a number of issues that do, if you like, limit the number of women that can give birth at CMUs. I've forgotten what your second the best start was the second question, wasn't it? I don't know whether Boyd wants to pick that one up. Do you want to pick that one up, Boyd, or do you want to pick me to do that?
I'll come in. You've said what I was going to say about CMUs. Just to caution, we should not set targets for the CMU. The 20% I am sure is an estimate. What we should do is benchmark to ensure that we are providing a quality service wherever that might be. And remember that some CMUs are a very short distance from a large hospital and others are a long way, and that changes the risk profile. We should be able to provide CMU services in Highland that are sufficient that all women who choose a CMU can have that option. And remember that the choice about place of delivery is based on the clinical assessment and risk assessment, and is also very much then a parent choice too. And we must work to always towards minimising risk, but ensuring that choice. And that could mean that the percentages go up, could mean they go down as well. But the key will always be, are we offering the right choice? Have we the capability that if everybody could and wanted to be in the CMU, we can manage that? And are we providing as safe as possible a service? So and that will be that's an ongoing thing, and we will. I have recently asked for benchmarking data with the relevant CMUs just to see where we're at even now. On Best Start, I think you're right, Anne. It's a very good question. The obvious answer is we mustn't drop it. It's very important, and whether it's incorporated into the maternity board that's going to now need to work forward with this latest report about Murray, or whether it works separately, I don't know the answer. But that what is a definite is that it wouldn't be dropped. It needs to be continued, and I would have thought the obvious would be to incorporate and make sure it's right up the middle of anything we're doing. But thanks for that question.
Okay, the assurance point, can we leave it just now till the end of the discussion and maybe get Pam to come in on that point later? Bert, followed by Jerry.
Bert, I think you're on mute.
Yeah, I've got a sticky button, sorry. Thank you, Chair. I think everything's been covered, actually. The point I was going to make, I think, was, excuse me, one made by Boyd Peters, which was about boundaries, which I think, as Boyd said, are very artificial. And when it comes to risk and the delivery of a service, I think that's a really important consideration, both in terms of Highland and in terms of Moray. But we're at a high level stage with all of this discussion just now. I don't want to get into the detail of it, but I'm very much assured by the input from the executives this morning. So thank you for that.
Thanks, Bert. Jerry.
Thank you, Boyd. I think most of what I wanted to say has already been covered, so it was really just to support exactly 100% what Pam opened up the discussion with. To me, there is many of the more important issues and the far more difficult issues are not really addressed in the Murray report. And if you look at the current situation as described in terms of poor information exchange, suboptimal clinical governance standards, etc., these are the things that need to be resolved. So I would 100% support Anne's view, and we'll come on back to it at the end of the discussion, in terms of we must have a subject to adoption of this paper. Thank you.
Thanks, Jerry. Deirdre.
Thank you, Chair. Just two quick questions. In the report, I note that Model 5 could see between 50 and 70% of babies born in Dr. Gray's based on the Northern Isles approach. Thinking about risk and safety, I wonder, what do the Northern Isles do differently to achieve this, or what might they have that we don't? And my second question is to do with community engagement, and the report quite rightly says that the patient voice should be at the heart of that. New mums are busy, they've got little babies to work with, so the time they give up to contribute to discussion is very precious to them. And I'm very conscious that over the past 20 years I've been involved with different campaigning groups. There have been a raft of stakeholder groups, public discussion, community engagement. So I wonder how much of the historical evidence that we already have and the communication with previous groups will build into the contemporary engagement. Some things just simply don't change, and I think there might be an added value of transitioning historical evidence into the contemporary engagement. Thank you.
Thank you, Deirdre. I think maybe Pam can clarify the first question.
Yeah, option 5, I don't know enough about to be able to give you the detail, but I suppose that goes back to the previous conversation that we have got diligence and detail to do around all of this, and that will come back at the right time. And today's paper wasn't to give you the end product or to give you all the details, to give the opportunity to comment and raise all these really important issues. And Boyd will maybe say a little bit more about that in terms of that model. But what I can tell you is that I did ask, a bit more about that in terms of implications for us in some of our situations. And they were very clear that the review group wouldn't comment in that context. They were very clear with Grampian that the ability to deliver that would require significant investment in Dr. Gray's as a district general, and would require a whole host of other parts of the service to be fit for purpose to be able to deliver what that ambition sets out. Thus the reason it's quite far away in terms of how doable they think that is. So they were very clear that would require the district general, that Dr. Gray's is supposed to be a district general, and the criteria for that and the requirements of that in order to be birthing that many goes way beyond maternity. So that was I think that was important. That said, we will look at everything and learn from everything that's comes in through this process, and as we look at our own context. Boyd, I think you might want to add to the option 5 aspect, or the Northern Isles context.
Yeah, can do. Option 5 is probably, to enable it would take a long time, and my reading of the report, I'm not sure that I see the neonatology there, because that wasn't a service present, and it's a service that requires a large population to support the service. And even for Highland, for us to increase our neonatology capability for here, and we have a significant population to serve, you could still argue that we have a marginal case in terms of the numbers. So there won't be, to my eye, neonatology ever in Grays, and that medically adds a risk to some deliveries. And with regard to the Northern Isles comparison, you can compare it to a certain extent. You must remember there are social factors and other factors. The islands are a distance from the mainland, and they're separated by sea. Now, forgive my Irishness, I'm stating the obvious, but to have your baby on an island, so if you're from Orkney or Shetland or wherever, and you were born and bred there, and you want to have your child there, and you want people to be born there, then to do that, you would, there's a service, but the service will have limitations naturally, and people will accept the risk and opt for delivery with some risk that if something goes wrong, they have to be transferred out. You can achieve a higher rate if people accept greater risk. I think that the risk discussion is really important, and that ultimately comes right down to an individual patient and the clinician and the knowledge of the local services and the options. Now, the services, the options and everything else will be different in Murray and what you discuss to any other part of Scotland, including the Northern Isles, which are particular in some of their risk challenges. And so you can only use comparisons to a certain extent, and then you always have to focus back on the area, just as we have to do for parts of the Highlands where there are risks because of where people want to deliver in Skye as they do. There is a risk because it's a long way from neonatology and from consultant obstetricians, etc. But for some people that's an acceptable risk, and for others they think, well, I might be okay, but I might actually prefer to be safer and be at a big centre just in case. And we mustn't presume. We should build systems to support people in their decision making, to support the clinicians who share the risks and describe the risks with the patient, and the patient makes the choice with their index clinician. But it's very hard to manage the risk in terms of setting up a service and demanding that's the outcome. We must respect that patient-clinician interaction and that individualized risk management. And two patients in the same circumstances could easily make two different choices. The services, wherever they are, and ours are in Highland, need to support those two choices. And then it's a matter of individual decision-making with the clinician about where ultimately the person will want to be. And so it's really difficult. And the report had a big challenge in trying to pull in a lot of strands. And of course it will, some will comment and criticize as well as support what's in it, because it can't cover everything. We must respect it and the government's decision. Back to the main agenda, we need to build services that are flexible and resilient for Highland, and I think for some parts beyond Highland, and that will include Murray by the looks of it.
Okay, hopefully that's at least partially answered your question, Deirdre. I'm sure Jerry could shed more light on it in a separate conversation, maybe offline, but meantime, we're being asked to accept 3 recommendations, and there is a concern around this, the degree of assurance that we can take from the report. But first of all, if we can just, Pam, do you want to come in on the assurance aspect, and then we can look at the recommendations?
Yeah, absolutely. And it is difficult in the context that we've not come to you and said we can assure you that they're doing A, B and C, and we've done all this diligence and we can give you sufficient opportunity to be assured. But I think it's really important that we are clear about what we've engaged in, which is first and foremost to see if we can be part of the solution to support women and families in West Murray from this report, to make the choice to birth in Raigmore, which is from a human perspective, I could completely understand that. I think we have all the, in the engagement we've had in this, and the task that the review team have had, we have tried to give the best estimate of what we think it would take. But we have also cautioned that that means right now we're not in a position to do this. I think going back to what Boyd said, Boyd Peters, that everything we do here needs to be in the context of our sustainable maternity services that need to be delivered within a best start context across Highland. And therefore, I think it's perfectly acceptable to note that we have expectations about that the board has expectations about what we would need to give assurance on going forward in order to feel that we can continue and progressing our own maternity strategy with or without money, depending on the outcome, and two, if that is the outcome, how that's incorporated into it. And you would be looking for future assurance that we could set that out well with you. My desire would be that our clinicians, as we work with them in the coming weeks and months anyway, are in a position where they feel that we're working hand in glove with each other, that we're not in opposition, and that we are taking a clinically led approach to this with a clear management challenge in there, because that's our job, to challenge and consider and work hand in glove with each other to deliver the best we can for the people of Highland. So I think in terms of assurance, I'm perfectly comfortable with the board seeking that we can do that with those that caveat is in place, that we do this right, do this well, and can present an appropriate target operating model and business case that's fit for the future and that the board can be assured about. And that includes the financial diligence that needs to be around this, because this is significant. If money comes in, it's significant investment. If they don't, it's significant potential investment in terms of our future model.
Okay, can I just go back to Anne to ask if she has any particular views on the caveat?
I think that Pam's, what Pam said there, she's mentioned a number of important points. I mean, for me, I absolutely, agree that we need to, in seeking to deliver the best possible services to the people of Highland, we need to think broader than that, and because a lot of our issues need to be solved on a North of Scotland basis, and therefore absolutely we need to be open to considering offering a choice to women in Murray. I think that the kind of caveats that Pam's mentioned, such as finance, such as our clinicians being supporting the development, and that the developments are in tune with our ambitions for Highland women are the three key things for me. So I'm afraid I can't do better than that off the top of my head. But I mean, I would be happy with something that referred to subject to the assurances provided by the Chief Executive.
I think that might be the neatest way of encapsulating that, Anne. Thanks. So with that in mind, are we content to accept the three recommendations before us? The establishment of a maternity services programme board to provide oversight, to developing the future model of maternity services more broadly, whilst ensuring the recommendations of the Murray report are encompassed. Second one, the board is asked to support the need to complete the service redesign of the Rigmore maternity unit to accommodate the care of existing and additional women and the completion of the business case. And thirdly, the board is asked to support the initiation of negotiations with NHS Grampian and the Scottish Government to secure revenue costs for NHS Highland. Are we content to approve these recommendations subject to the assurance that Pam has provided about process? We are, okay. Well, that's been a longer session than anticipated, and our timings are all askew now, but I think we must take a break, a comfort break, and come back 12:15, and that will have a knock-on impact in our timings for the rest of the day. So don't set your body clocks for lunch at 12:30 or something.